Are you ready, Nigeria? Ili Ends Health Society, in partnership with Dental Technologies Consult Limited, presents exclusive ends on dental implant training. Gain real-life knowledge for success in implantology. It involves online classes as well as in-person workshops. Procure the equipment and supplies you need to run a profitable implant practice. Facilitator, Dr. Uvoh Onoriobe.
I've heard so much about implants, but this was, let me say, this is a practice-defining lecture and experience. I would definitely recommend it to others to participate in the program next time.
For inquiries, contact Ego on +234-802 322-9290. For more info, visit www.8ends.org/courses.
So Rebecca Steffens is just graduating as an endo resident at the University of Michigan, you know, I see all the work they do, and I know that I don't know where are you moving to after this?
We're actually going to head to South Carolina, but I am from Texas. I saw some Dallas. I'm actually from Dallas, but okay. We're going to go to.
All right, I'm going to leave the rest of the introduction to you, so please go ahead and take it away.
Yeah, thank you, Dr. Uvoh. Thank you so much. I'm really excited to be here. I know we met, I remember when I first met you almost 3 years ago at our orientation, and we've shared quite a handful of patients. So like Dr. Uvoh said, I am kind of a newer grad from the endodontics program at Michigan. I did practice as a general dentist, though, for 4 years prior to starting my training. So today, you know, I was asked to just speak about an introduction to Rotary endodontics. So when going through and making this presentation, there was a lot of things going through my head, all the information I've obtained over the past couple of years, but I really kind of thought about things that I learned that I wish I would have known as a general dentist when I was working. I was doing quite a bit of endo. So I just kind of kept it a little brief. We'll kind of go through everything and then hopefully give you some tips and tricks. Even if you can just walk away with just learning one thing from this, I know I'd be happy. So let's get started. Let me move this over 1 second. Sorry about that. Yeah. So today, here's our contents, what I'm going to be covering. So why Rotary endodontics? We'll talk a little bit about the goal of root canal therapy. You know, why are we all doing this? Stainless steel files. So I did put in some of the abbreviations we sometimes like to use. Nickel titanium, the Rotary files, or NiTi. And then hand files, kind of comparing them versus the Rotary files. Next, we'll look at really what it's all about is developing a protocol. The big thing I found out when I started my training is if you ask an endodontist or even a general dentist what their protocol is, how they go about doing a root canal, everyone's going to give a different answer. So I think the important thing is to understand these basic principles. And then from there, you'll kind of develop your own protocol, your own instruments, all those good things. So we're looking at access, glide path, working length, patency, and then I'll just briefly talk about some of the Rotary file systems and techniques. I'm not going to get into too much of metallurgy, all these specifics. That's kind of another day, another presentation, but really just the taper, looking at constant versus variable, the Rotary movements, whether it be rotation versus reciprocation movement, and then the technique maybe you're using with the files going through sequence. So maybe sequential versus a crown down. And then just briefly on obturation, depending on what Rotary file system you end up using, sometimes you may tweak your obturation kind of to match. And then last, I'll just end with some cleaning and shaping pearls, some tips and tricks, a little bit on lubrication and irrigation when you're going through your protocol, single use versus multi-use files. That's a kind of a question I get a lot. How often are you using them? And then lastly, just file separation and prognosis. So to start, why Rotary endodontics? Like I said, in this picture, kind of sums it up a little bit, the instruments we're using and the goal we're kind of trying to get to. So first, the goal of root canal therapy. So I started with just the American Academy of Endodontics, or the AAE. If you go to their website, if you just kind of Google that, and then Colleagues for Excellence. So they developed almost similar to like a newsletter that's really, really nice, very straightforward. So you can follow this website and go, and I believe they're free. They have nice PDF downloads that they will update pretty regularly, whether it be from just standards of care, CBCTs, just all different types of things that we deal with in endodontics. So it is good to get in the habit of maybe even just browsing these every 6 months, even if you can just once a year, to kind of see the new updates of trends, thinkings, everything like that. So again, the goal of root canal therapy. So first, we want to remove irritants from the root canal system. Keeping in mind, we want to lower that bacterial load to allow the healing of apical periodontitis. Second is to obturate or 3D fill the clean canal, 3D fill the clean and shaped system. So really with that goal, we're providing an impermeable fluid tight seal within the entire root canal system, and really entombment of the bacteria in the canals, which will deny them access to periradicular tissues. So we're next look at preventing future recontamination of sealed root canals. So what that is, we're hoping we obtain this apical seal, and then just as important is a coronal seal, whether it be a permanent restoration to seal in all of our obturation material, or a crown, things like that. So there have been studies that have showed that of extracted teeth following root canal treatment, 85 to 94% of those were without crowns. So we're kind of, a lot of patients, do I have to get the crown after I get the root canal therapy? And we do have a lot of literature showing it is recommended. There also was some studies that even noted that the quality of the crown can be more influential on the outcome of your root canal than the quality of the root canal itself. So just keep those things in mind. And those are things I always try to explain to the patient too, whether it be I'm going into the root canal, but also following all the way through to the restoration. So looking at, before we get into cleaning and shaping, we just want to always keep these kind of objectives in mind. So Schilder went through these main objectives. So first, looking at the root canal preparation should develop a continuously tapering cone. Next, that cone will be kind of decreasing in cross-sectional diameters as we move down towards the apex. And then again, with that in mind, keeping increasing diameter as we get more coronal towards the orifice. Next is that preparation should be in multiple planes, kind of maintaining that concept of flow. And then one important is we do not transport the apical foramen. So that kind of gets into specifics of the anatomy of that apex. We call it like almost a constriction that we really want to maintain. And then last, that the apical opening or that constriction should be kept as small as practical in all cases. So moving forward, we'll kind of start first with stainless steel hand files, kind of getting, when I thought about this introduction to Rotary, I kind of assumed, a lot of practitioners may still be using hand files to accomplish what we are doing with these Rotary files. So these files were similar, have found similar bending and hardness properties as these carbon steel counterpart files. So like Uvoh said, I'm kind of a newer DDS, newer endodontist. So I haven't necessarily worked with carbon steel files, some of these older instruments, but I know all of my training has been with these stainless steel hand files. So they have shown to have greater flexibility and resistance to fracture by that twisting and grinding the way they're made. And then there have been quite a few studies that have shown a resistance to corrosion by sodium hypochlorite. So that's kind of what's brought them kind of to the forefront over those carbon steel counterparts. So there's lots of different hand files you can look at. The two that I kind of tend to put in I call it my toolbox, are these K files and then Hedstrom files. So first looking at these K files, so on the picture, it'll be the ones on the left, that green one with a 35. So these are manufactured by twisting or a grinding process of a square or triangular tapered shaft. And so you can see, like I said in that picture, these cutting edges are actually perpendicular to the long axis of the file, and they're produced in a way that gives the operator kind of this smooth tactile sensation. So with those features, the K file ends up being kind of a little bit of the workhorse in your protocol, at least in mine. So these files, again, have a 0.02 taper. So I'll kind of get into the meaning of that a little bit further into the presentation. And then if you were to cut the file, the end of the tip, and look at a cross section, it would be a square cross section that we may see, and a lot of studies have gone in to look at these shapes. So one thing I've kind of just little tips and tricks. So when you look at these files, you can see the square cross section. So that square on this file, keep that in mind. That's how we know that's a K file. where when we get to the headstrums, you can see this 45 has that circle. With those K files though, so I've taught a lot of dental students, the concept we're trying to get across is this balanced force use. Some call it like a watch wind, very small movements. And with that concept, it's kind of, like I said, become the workhorse file for me and kind of the most commonly used. I do recommend at least having these in your armamentarium, these headstrom files. So that's pictured on the right here, kind of more of a screw look. So these are manufactured by machine grinding round wire blanks. The flute depth increases with taper, creating a sharper, more flexible file. Again, these have a 0.02 taper with a round cross section. So you can see it's depicted with that little circle. And these are more for circumferential filing, almost similar to like a screw. You don't necessarily want to pre-bend these. And then I personally use them more so to engage. I'm kind of going in, engaging maybe bulk pulp tissue. If you have a very vital case with a lot of bleeding, I'll right away go in just to remove all that tissue out. With retreatments, I'm using these also for removal of gutta percha, things like that. Anything to kind of engage the material and then remove it from the canal. Next, a little brief history on the nickel titanium or NiTi, the rotary files that we're going to get into today. So just brief history. In 1963, was Buehler developed a nickel titanium alloy at the Naval Ordnance Laboratory. So that's how they kind of came up with this name, nitinol, where it's the nickel titanium and then nol, the Naval Ordnance Laboratory, or NiTi. So sometimes you'll see that in a lot of the literature. It'd be called nitinol. This alloy, though, is composed of 56% nickel with 44% titanium by weight. And kind of started this conversation in 1988. Walia had a study that compared these experimental size 15 NiTi files that were fabricated from ortho arch wire blanks with a 15 stainless steel hand file. So these are depicted on the right. So through these tests, they kind of ran through 3 different testings of the materials in the files and found that the nickel titanium had 2 to 3 times more elastic flexibility in bending and torsion and superior resistance to torsional fracture compared with those stainless steel. So that's kind of what started this conversation with these nickel titanium. Again, looking at a little bit of a comparison between those hand files, the stainless steel hand files versus these nickel titanium rotary files. The NiTi has been found to be more flexible and more resistant to fracture compared with stainless steel. The NiTi is highly resistant to corrosion, highly elastic and fracture resistant. We'll kind of get in a little bit to the properties of the nickel titanium files. So they exist reversibly in 2 forms, this austenite and then martensite, depending on the stress on the file and then the temperature. So there've been a lot of studies that have shown that while stainless steel allows a 3% elastic deformation, this nickel titanium in its austenitic phase can withstand up to 8%. And then again, the stainless steel withstands up to maybe 20 bending cycles, while nickel titanium up to 1,000. So it also has been several studies that have shown that root canal preparation using nickel titanium rotary files results in significantly less canal transportation, fewer procedure errors, and better maintenance of working length compared to these stainless steel hand file preparations. So these are some pictures I came up with. Like I said today, not getting into brands, anything like that. It's just really understanding the principles. So this is one of a nickel titanium file that I use pretty often. So these features that we were talking about, the phases that these rotary files can go through, there's this austenite and then martensite. So through the treatments, everything, the way they were fabricated, one of the features that this nickel titanium provides is called super elasticity. So you can see complete recoverable elastic deformation up to 8% strain due to phase transformations between a stable austenite kind of phase to this stress-induced martensite phase. So let's say we're in this stable austenite phase on the picture on the left here. The file is straight. And then I just wanted to see the flexibility of these files where they can stay in this once stressed martensite phase where they're not necessarily bouncing back straight where you may have seen with these older non-nickel titanium files. Another thing, which it depends on what system you're using. They've kind of developed them even further where they're giving these files, it's called like a heat treatment or thermal treatment. And so shape memory or controlled memory. There's a lot of different terms that have been out there. So that's the ability of deformed nickel titanium to recover its original shape when heated due to phase transformation of stable deformed martensite to a stable austenitic phase. So I think depending on what system you're using, if you're using a nickel titanium file, look at the manufacturers, kind of really dive deep into some of the information that you can maybe even find online. So they will provide the super elasticity, but depending on what system you're using, you may not have this shape memory. So with the shape memory, this is one thing I take advantage of a lot, is I'll take endo ice and you can cool the file, and you can see the flexibility is just pretty amazing. And so say I'm doing a second molar, things like that, places that are hard to get into. We all know with the bending of the file, I'll actually pre-bend them, kind of freeze it with the endo ice so it stays in this curved shape, and then it's much easier for me to kind of maneuver it where I need to maneuver it. Next, so we're kind of getting into developing a protocol. So when I started the program, the big thing I always think is I'm trying to have this toolbox when I'm at work that I mentally just fill with all the knowledge I've obtained kind of through mentorships, clinical tips and tricks, colleagues, all these different types of things, or even this seminar. So I'm hoping the big thing is to develop a protocol that you're comfortable with. And like I said, you can ask 10 endodontists their protocol and you're going to get 10 different answers. But the principles, I think, are all still very the same. Again, so we're going to talk a little bit about access, glide path, working length, patency, rotary file systems and techniques. So specifics of the taper, the movement, the technique you're using with the file, and then the obturation. So first, looking at access and glide path. So access, straight line access and coronal flaring. So straight line access, I couldn't necessarily find a good picture. I know this is kind of more of that basic when you are accessing these teeth, especially if you're just starting off with endo. Not to say bigger to me is a little bit better. I would teach a lot of dental students, and I know everyone wants to keep their access so small and so conservative, which is great. I think they're keeping in mind the restorability aspects, but for endo, especially when you're just starting off, it's much better. I always tell the students to kind of have this straight line access, then work in this kind of undercut access where you're going in with your burrs, your handpiece, and trying to undercut your enamel, and it can lead to more perforations, more issues, where if you can just see everything, see what you're doing down, at least starting off, it's better to kind of have this bigger straight line access. Next is coronal flaring. So this can be accomplished with an orifice opener. So I always explain to the students, it's this one, if you buy a set of rotary files, typically if they do provide an orifice opener, it's always the one that's a little shorter, and then it kind of has a little bigger flutes. So as soon as I get my straight line access, I'm going in with my orifice opener. And then both of these things, I do recommend performing them before determining the working length, just because things could change your straight line access. If you need to change things in your access, that can affect your reference points for your working length. Again, coronal flaring, the advantage is it's going to provide that straight line access. So to me, this picture on the left really shows the difference between maybe this smaller access they made, where, yeah, of course, they got into the canal, versus the straight line access. And what it really does in the long run is it kind of provides less stress on that file. So coronal flaring with that decreases the incidence of file separation. And then more importantly, it also provides coronal escapeway for irrigants, debris, and then which overall can reduce blockage. So again, keeping in mind everything I think for endo always starts from the beginning, and everything adds up all the way to the end. So doing this from the start just saves time and some headache that could possibly come with it. Next is glide path. So glide path is basically having your hand files make a path, an unobstructed path for those rotary files. So you really want to accomplish this before introducing any of your rotary files in. So I'm typically I'll usually start with a 10 file. As soon as I get in, if I do feel some resistance, I'll immediately jump down to an 8, a smaller file. Like I said, and then I kind of get to that length that I feel happy with. So stainless steel hand file preparations of the apical third before introducing rotary files led to kind of significantly decreased rotary file breakage. Again, to establish this glide path with those K files, we want to use that balanced force. So that concept is using a clockwise and counterclockwise motions that give more control, and then they allow enlargement of the canals past curvatures. So I would just try to explain it as you're going inward, because I'll see students using them and they just shove the K files down. So you want to go inward, 90-degree turn with some pressure, and then let almost kind of release that pressure a little bit with a counterclockwise, at least 120, but going back counterclockwise. So what you're doing is just thinking how you're loading that file with debris, kind of making headway for the tip, and then pulling that debris almost out a little bit. So you're kind of that, we call it watch winding, or this balance force to get that file to go to length. Next, looking at working length and patency. So I'll establish that glide path, and then we kind of hone in on that working length exactly. So again, I'm using either a number 10 or number 15K files for my working length. So the important thing for working length is choosing good reference points that are reproducible, whether that be the cusp tip, or if you have a crown, the crown tip, all those things, the anatomy, or maybe you need to change your access shape, and then measurement controls is very important. Same thing, depending on where your reference point is. So files, I know these rotary files and hand files will come with these stoppers, these rubber stoppers. So those are what I'll typically use for measurement control, as well as if you are able to purchase hand files, these hand files that have these tick marks on them. I never knew what they were for until my training. But if they have these black lines, that bottom one is always 18 millimeters. So right off the bat, if depending where your working length is, you're using that reference point, so you don't have to necessarily measure the file every single time. So when you're creating your protocol, it is nice if you can get some of these hand files that do have the tick marks on them, because it's just much quicker as you're going through sequence to take that to working length, and maybe not have, if the stopper moved, all those things that can happen to maintain that measurement. Next, looking at the working length. So what I personally do is I have this x-ray on the lower left. We use a program that, and I think some of more of the modern programs now, you can have a ruler feature that you're able to measure the tooth. So I'm measuring from apex down to maybe central of the crown, or picking a cusp tip that I may use just to get that estimated working length. As I'm getting in, I'll use that. A lot of times if I'm unsure, things kind of lengths, maybe it's kind of big difference from the working length, I'll take what I call working film. So with that, I'm just staying with that number 10K file, placing that to length, taking an x-ray, seeing how that looks. And then last is that apex locator, the electronic apex locator. So that's in the middle. If you are able to get one of these and use this, then I'll hook that up to the file, that 10 file where it's in place, and then really hone in on this exactly where I want my working length to be. Just some tips, kind of the apex locator could be its own presentation, but just some tips and tricks with that. So depending on the model and which apex locator you have, I do recommend that the canals, say you're doing a molar, 3 canals, it doesn't necessarily have to be completely dry when you use the apex locator, but you don't want fluid in between any of the orifices. So the chamber should be dry, but each individual canal doesn't necessarily have to be. Same with if there's bleeding, there's just things that can always throw the apex locator off. Reading the manufacturer's instructions, recommendations, and then of course attending lectures, things like that can help get you tips and tricks on how to make sure you're using your apex locator effectively. Last is patency. So patency, I'm maintaining with a number 10K file. And what that is just this recapitulation to prevent apical block and to maintain the glide path. So as you're cleaning and shaping with these rotary files, what can happen is you can get kind of a debris block, all these things as it's cutting the dentin. I'll go back in and I'm using a number 10K file, taking that to working length. So you can see in this picture and just past that constriction. So you're just keeping the constriction patent, maybe even half a millimeter, not even a full millimeter, just past, I'll go just past, and you're also maintaining that glide path for the next rotary file. So you just kind of get in that habit between going between rotary files, checking to make sure you have that patency maintained. And then there have been a lot of studies with patency. So they have shown that there's less post-op pain when patency is maintained using a number 10K file in these non-vital cases. For rotary systems and techniques, So I just pictured, like I said, I'm not getting into specifics. Some of these different setups that you can have. I've worked in a lot of different types of offices that have had a lot of different types of systems and tech systems. So can find them on, I even going through eBay, all these different things on the left. This is kind of the pretty standard, and you can go through and change speed, torque settings, it's like gear. You can pre-program them depending on which system you're using, or changing between file settings. On the lower, you can also buy these cordless ones. And then there's just one here I showed. This one looks like it's a little bit smaller, but same thing, where you can see all the features of what the torque is, the speed that the files are running at. And then a lot of them will have programmed to where it'll change the settings based on what file you have in. So I do recommend if you do are switching or using a rotary system, you have sponges. These are just pictured, kind of this typical, you'll see after root canal is finished. And then I just pictured some of the files that are available. So we will be talking, and like I said, this is just briefly touching on some of the concepts that I kind of stood out to me going from working as a dentist to now where I'm at now in my training. So the taper of the files, we're looking at a constant taper versus a variable taper, the movement that these files can have, either a continuous rotation versus a reciprocation, and then the technique you may be using to get the file to length, whether that be sequential or crown down. So first, taper. So I think if you can really understand this, it really will help make a lot of the other steps throughout endo and root canals, things like that, easier. So just starting with a standard taper. So it's just a constant. For standard, you're keeping that taper constant the entire length of the file. So what that means is, let's say we have a file that a size 3004, and files, they can be written in a lot of different ways. Sometimes they'll put 30-.04 or 30/. So here I usually use a period 3004. So what that means is we're taking a size 30 file, which means the tip diameter is 0.30 millimeters. And the next number, the 0.04, indicates the taper. So with it being a standard taper, every millimeter you go up on the file, you're going to add 0.04. So that's it just is going to constantly change as you increase the height of the file. You can kind of picture it in this lower right, but I know I try to show here with this bigger one. So for example, if we had the 3004, again, that tip diameter is going to be 0.30 millimeters and a constant taper of 4% or 0.04. So say I wanted to cut off, or the width of the file 3 millimeters up. So we have the 0.300 tip plus 3 times that 0.04 taper. So we get 0.3 plus the 0.12. And so let's say we were to cut at that 3 millimeters high, the diameter is 0.42. So one advantage to me with standard taper is that something that you could mentally calculate, and the taper can kind of stay forward with your obturation. Again, I just wanted to keep in mind with this 10 files, so they have a 0.02 taper. So the tip would be 0.10 for a 10 file. And say you were to cut off 1 millimeter from the bottom of that K file, then you would have in hand a 12 file, or 0.12 at that tip. Looking next is a variable taper file. So these I think, becoming a little more common. So you'll have a progressively decreasing percent taper. Again, so this picture kind of explains it. Instead of it constantly, say at the tip, there's just, as you move up the file, the taper percentage is changing variably. So for example, this red file, the 2507, and sometimes they'll put a V for variable. So with 25, we know the tip diameter is 0.25, but as we kind of cut up a millimeter, for this file in particular, it has a fixed diameter at D1, which would be at 1 millimeter, 2 millimeter, 3 millimeter. Then it'll progressively decrease as you move up the file. You can see to the 6% and the 3. So comparing it to the one we did with the standard, let's say we cut off 3 millimeters of it, or at that 3 millimeter height on the file, the diameter would be 0.25 plus. And so just for those 3 millimeters, it was affixed at 0.07 times 3, and then you can see we get to 0.46. But if you were to go higher up to the 4, changing in where the taper changes, you'd have to kind of accommodate the different taper. Next is different types of kind of file movements. So there's just a rotation or that continuous 360 clockwise rotation. So a lot of the literature kind of talks about that with the development of these nickel titanium files, we are very excited about the super elasticity properties. But what can happen with that super elasticity is they noticed these files kind of had more torque sensitive, which led to separation. So that led to the development of these, I wouldn't say newer, but reciprocation. So it's just kind of a different type of movement. I was going to try to post a video, but I always just explain it. Instead of just going continually in a circle, it's almost like this back and forth. So it's an asymmetric with a counterclockwise cutting and then a clockwise release. This short, so this picture down here kind of shows it, maybe a 150 to cut, and then this fast little release that will disengage the file. So generally, this reciprocation movement reduces increased torque on the file, but does so by cutting and releasing debris into the canal. These are typically single file systems, meaning that one file is going to be used to remove a large amount of dentin, while also keeping using that file to prepare the final shape, or that will be the master file. So reciprocation showed a significantly higher cyclic fatigue resistance compared with rotation. And then I had a conversation with my mentor about that. I think these files, because even just colleagues, they offer this fast release. Some practitioners, you may feel more comfortable using this file, that less separation, things like that, because you're not necessarily having to gauge yourself how much pressure, movement, all things that are going on. The file definitely is going to release on its own. So there was a study in 2018 by Hamid and others that found that switching dental students to this reciprocating file system resulted in superior immediate clinical outcomes compared with the previous hybrid technique that used tapered rotary files and then apical finishing with K files. After speaking to our program director, that's kind of similar what we found at the dental school that we are at. So these reciprocation systems can be really good if you want to invest in one of these. Some of the other benefits would be, because they have a single file system, you could be purchasing less files. On the other side of that, these single file reciprocating systems, there have been studies that have shown they've produced more debris extrusion, dentinal cracks, and post-op pain. Again, with that cutting and releasing, we kind of know it is going to be releasing debris into the canal, and depending if you're kind of not irrigating, things like that, that debris has nowhere to go. It's going to be pushed through the apex. So you just have to keep those in mind if you do go with this system. Lastly, it's just the technique using the files. So like I said, this is just a brief outline. One method, and this is kind of what I'm using right now, is a sequential enlargement, depending on what file system you're using. So I'm just essentially using these files in a smaller to larger sequence. And because I'm kind of starting so small and going up, I'm just doing a single pass with each file. So back to, I'm having my access, my glide path, I establish my working length. That glide path is up to a 10 or maybe a 15 with the K file. I have that path ready. Then I'll enter in with starting with the smaller file. So if you see this picture on the right, the white one at the top is a 1504. So thinking about that tip diameter, it would be 0.15, very small, just slightly bigger than my K file, where that taper is constant. You can see at a 0.04 taper going up the file. So I'll go to the 15 single pass. I don't expect many obstructions, anything, because my glide path is already made for this file. Irrigating, maintaining patency, and then going to the next file. So I'll go all the way up to the sequence that I want to stop at my master file. Another technique, depending on that you may see with these more variable tapered files, would be crown down, or sometimes they call it the crown down pressureless technique. So with this crown down, it's essentially just incrementally removing the canal contents and dentin, proceeding from the orifice to the working length. So this typically can take maybe 2 to 3 passes of the file. You're not going to get to working length in one push. So you really want to be careful to avoid having a lot of apical pressure. And as soon as you kind of are going in, so just imagine you're kind of taking this bigger file or this file and making it kind of forming the canal to that shape. So as soon as I feel resistance, I'm taking that file out and I'm cleaning the canal, irrigation, cleaning the file, and then maintaining that patency, making sure that path is ready for the next kind of run with the file. So this is just an example of what you'd see with a variable tapered system, and then where you may employ this crown down technique. So kind of comparing the two, you can see where the taper on the right, these percentages is varying as the file is getting bigger, the tip diameter of the file gets bigger. So these you probably are going to have to take, I always say, a couple passes to get to that working length and then move on to the next file. Lastly, just briefly on 3D obturation. So a lot of different obturation techniques. For me, I'm using gutta percha. So I think the big thing to take away when you understand the tapering of the systems you're using, that the gutta percha cones that you use can follow those same taperings. So for those standard tapers, I'm using standard gutta percha that has the same taper. So when I'm choosing my master cone, my gutta percha cone, I may kind of match those up first. I'm seating it to length, and then I'm checking for what we call this tug back or this apical resistance. So this picture on the right shows you really want to have binding just in that apical third. You can have what's called false tug back, where it's going to length and maybe you feel this slight resistance when you take it out, but it's actually not binding at the apex, it's binding maybe mid-canal. That's why understanding the taper, if you can understand the taper of the files you're using, it makes it a lot easier to understand if you need to make adjustments to your gutta percha cone, assuming these taperings are the same, that you can feel comfortable cutting off a millimeter, knowing that that'll correlate to maybe the next file size. And then not to get into specifics, but for obturation techniques, this is just really broad, just talking about maybe like a single cone technique, where it's sometimes called sealer based, versus a continuous wave of condensation, which is kind of a modified warm vertical technique. So with that single cone technique, principles, you kind of maybe thinking it in a little bit different way than this warm vertical, where the gutta percha is a delivery tool to help generate hydraulic pressure that's going to distribute that sealer. So for this technique, I kind of have this pictured on the right side, assuming you clean and shaped everything, irrigation, you dried the canal, you could be placing your sealer. Sometimes they'll have these modified tips to fill just half, the coronal half of that canal, and then lightly coat your gutta percha cone, and then just slowly seating that to working length, nice and controlled. And then you're just burning off. So that idea is that that cone's going to go in, apply that pressure to push that sealer laterally and really seal everything up. And then maybe you're just burning off right at the orifice. So for this technique, though, I do recommend that the choice of sealer is pretty critical. You want to have one that has excellent flow and dimensional stability. So these calcium silicate based sealers, bioceramics is a term you may see, or bioactive. Again, I think it's just important to talk to you, look at the manufacturer information, look online, just be educated with what material you're using if you're going to choose to do this technique. And what these bioceramics offer, it forms a hydroxyapatite-like precipitants at these interfaces, which they've just shown can improve the seal and then promotes healing. So sometimes I'm doing this technique, like I said, it's kind of these case selective that I'm changing. The second one we're going to talk about is continuous wave of condensation. Again, so this is kind of a modified warm vertical that Shoulder talked about. We're using heated pluggers that will be taken 5 to 7 millimeters from working length. So I'll kind of show you in this example on the right. We have these heated pluggers with known tapers as well. I'll sometimes, before I fill it, kind of check to see the depth of that plugger, making sure it goes from 5 to 7 millimeters. Once I'm ready, sealer, cone, seating that cone, and then you're actually taking this heated plugger, kind of burning off, leaving about a 5 to 7 millimeter apical plug, condensing, adding a little more sealer again, and then you're going to backfill the canal with thermoplasticized gutta percha. So for this type of procedure, you can see this setup, these pictures here. You'll have a heating instrument. It almost looks like a little pen with these condensers that the sizes are varied. You have known tapers that could be matching your tapering of your system. And then for the thermoplasticized gutta percha, we always call it like the gun shaped one, or these newer ones, these elements of the pen. Both are accomplishing the same thing where you're heating it, placing that plugger in. You do want to make sure you kind of touch that apical plug that you've left, and then just slowly backfilling and condensing with the idea that you're just compressing everything, all of that gutta percha, to get a nice tight seal. Lastly, I'm just going to end with just some kind of clinical cleaning and shaping pearls or tips and tricks that I've kind of picked up during my time. So lubrication and irrigation, a little bit on single file use and multi-file use, and then file separation and prognosis. So for lubrication and irrigation, I do suggest having these three on hand. So there's these gel-based lubricants, some of the brand names, Endogel, RC Prep, but you can find them online. So typically they'll come in either dispensed with these single-use little containers that you may see, or you can buy a tube where I'll just dispense just a little bit, no bigger than the size of a pea, a very small amount on my sponge. So these lubricants contain EDTA, urea peroxide, and then glycol. So this provides lubrication and removes calcifications. So I do recommend using these though, if you're going to use, we call it like a gel or lubricant, just with your hand files. There have been studies that have looked at that if you're going to use, you kind of need any type of lubricant or EDTA. These aqueous solutions have been superior to these gel-based when used with rotary instruments. So I'm using these strictly with hand files, and rarely or never am I putting these lubrications on my rotary files. Next, again, we all kind of know sodium hypochlorite, providing antibacterial, removes debris, neutralizes organic compounds, biofilm removal, and provides lubrication. So what I recommend instead of this Endogel for the rotary files is you're flooding your axis cavity with sodium hypochlorite in the canals. So that would be your lubrication. And then those rotary files are going into working length out, and then you're changing out that reservoir and the irrigation as you go through. Last is the EDTA, the ethylene thiamine tetracetic acid. So this is that chelating agent. So for this, like I said, depending on the rotary calcification things, I'm sometimes putting a dot of this in if running into calcifications, things like that. But I'm definitely using this for my final irrigation rinse before I put the gutta percha in. There's been studies that have shown that this final rinse with 10 millimeters of the EDTA followed by 10 millimeters of sodium hypochlorite is just giving these really clean dental tubules, very patent areas, so we know our sealer can get in. So a little bit on single-use, multi-use files. So files do come pre-sterilized due to prions. So autoclaves that we have do not kill prions, and these protein particles cannot be completely removed. So for those of you who don't know, prions they're these proteins that can cause fatal brain diseases such as mad cow disease, or kind of the human version. So with additional usage of our rotary files and hand files, the chance for instrument separation will increase. So sodium hypochlorite in EDTA has caused significant deterioration of file surfaces. Studies have shown that autoclaving more than 3 times unused, these GTX rotary files, led to a reduction in torsional strength. And then we briefly talked about those heat-treated rotary files. So autoclaving those new heat-treated rotary files actually extended the cyclic fatigue life. So keep all those things in mind. What I really recommend is developing a system for your office and your clinic. Like I said, I think working with your assistant and explaining for them, either whether it be, I've seen where you can score the handles of the rotary files, so not where it attaches, but kind of close to those markings, just putting maybe 1 score on it with your burr once you're finished with the procedure to know it's been used once. 2, maybe when it hits 3 times, you're tossing it. Another system I've seen is using these taking advantage of the colored stoppers, changing these out, maybe like a red, yellow, green use of 1, 2, and 3, things like that. Or having a nice sponge system like here on the left, where you're placing certain files in certain areas, so you know. Just developing whatever your system is that you and your assistants have to make sure you kind of are using the most of the files, but that you can keep track of everything. And then just little tips within that, always cleaning the biggest canal first, so the one that the files going to kind of bind the least on, followed then to the smaller ones where it's maybe getting a little more work. And then always checking the files for irregularities. I work with a microscope, so I always, when everything comes out and in, I'm always taking a quick peek. I used to work with loupes though. Those are great. It's really just about maybe shining light on it. I know sometimes you can see in this picture with the hand files, when you see them unwind, I would toss it. With the rotary files, to me, it's sometimes a little more difficult to see. It's really about if those fluids have a change in light on them. To me, that's where I know there's a small discrepancy in it, then I'm tossing it. The biggest thing is you have this system, but you're checking the files. When in doubt, throw it out, because that takes us to our next file separation and prognosis. So it's going to happen, especially if you're doing a lot of endo, you're using rotary files. You can see in spite of all the advancements in flexibility, file fracture, or we call it separation, still is going to occur. Why do these files fracture separate? So there's kind of two things that are going on: the cyclic fatigue and torsional strain. So cyclic fatigue is when a metal is subjected to repeated cycles of tension or compression. So this really plays in, I think, about just even from what we talked about at the beginning, this straight line access. If you're not providing this file, this straight line access to then take a curve, and it's having to take a curve almost like an S shape and then come back to get to the apex while it's twisting, you're just going to experience more of this. Last is this torsional strain. So that's basically when the tip of the file is locked and it continues to rotate. So that's why we want to have that light apical pressure. You're never forcing a rotary file, or it can lead to this torsional strain. And then last is what to expect if the files do separate. So like I said, it can happen. There have been studies that have shown, though, that separated instruments have no statistically significant effect on prognosis. I think a lot of that depends on where the file is separated, and then at what point in your procedure. Very early on, prior to getting irrigation, cleaning it out, or was it more so towards the end where maybe you were able to take the file, clean the canal out, irrigate, things like that. So just going through your head, depending, you take an x-ray, you see where it's at. If you're unable to remove it, you can either bypass it, starting with hand files, leave it in its place, and then maybe approach its removal, or intubement surgically.
Yes.
And then these are just pictures showing some different ways that we try to remove them. I think a lot of these, though, it can be difficult without the use of a microscope or very high magnification. And then last, this is just some tips. Keep in mind to prevent a file separation from happening. Again, I think number one is this access, glide path, working length, patency. Establish those very early on. You're confident. Then as you move forward, it decreases the chance of these issues happening. Using a bite block or a mouth prop, more so kind of patient comfort, of course, but it just ensures that, especially if you're working on a back tooth, things like that, you have that rotary handpiece in. You don't want them necessarily closing down a little bit to cause a separation. Measurement control, again, getting good reference points, using stoppers, things like that. And then depending on what system you use, not skipping files, using them in sequence. You don't want to jump to your final file, trying to force that to length if you haven't cleaned the canal and it's not ready. Again, never forcing a file, copious irrigation throughout, maintaining that patency, keeping the rotary file moving. So you never want to kind of go in, get midway, stop, and then start it again. That can just add to that cyclic fatigue. Inspecting the files again for any discrepancies or irregularities. Reuse the file. There is no magic number. It's just important to develop that system, and then always examining these files for wear and tear. And then lastly is just being prepared, taking multiple pre-op radiographs, looking for curvatures, looking for canal splits, things like that, developing that protocol, kind of having all those tools in your toolbox. And lastly, just never blaming the file, which I don't know, sometimes you just have one of those days, but here's just a list of my references. And then that's it. You can take some questions.
All right. We do have a lot of questions. All right. I'm going to get, I think I would allow Arnold. Arnold, are you there? Arnold, just introduce yourself, where you're calling from, and what your question was. You're able to talk, Arnold. Go ahead. Dr. Mahiga. Yes, go ahead.
Hello?
Yes, go ahead. I don't. Yeah, go ahead.
Between the crown down technique and the sequential movement, which one is superior to the other?
Superior in terms of, I think, honestly, they're both, so I think you could say the endpoint's going to be the same, right? You're still ending in this master file that you're using that to move forward with the obturation. It just depends on, not to say your experience. I think depending on what system you choose to, that's going to fit your office plays in. The reality, some may argue that sequential is going to take a little bit longer because you're kind of going, I'm not skipping a file 15, 20, 25. If I'm ending at a 30, maybe it's 4 files, where crown down, depending on those other reciprocation file, you're maybe given 2 files, but you're going to have to sit and do 3 or 4 passes to get to length. So I can't necessarily push one or the other. Some may argue that depending general dentistry, if you're not doing endo all day, every day, you're buying less files with ones that you may use a crown down technique. There's less files involved. It may be faster, kind of cost wise. Whereas, but it's kind of too with experience. If you're kind of running into issues, you're getting canal blockage, you're spending more time remaking that glide path and patency, you may be more comfortable where when I'm using sequential, I just know that each one's going to go with kind of minimal resistance because I'm just incrementally going up. I'm not sure if that answered your question. I hate to say it's just kind of, it's user dependent. I wouldn't say there's one that's superior.
Okay. There's another question there by someone, I don't know who that person is, but it says, is there a specific calculation on how much the canal should be enlarged?
Great question. So yes and no, I would say there's not a magic file number. The biggest thing is we want that irrigation to get to length. So there's a study by Peters that showed he took micro CTs of teeth and they dyed them. We're able to see that after just cleaning and shaping with just files, just rotary files, about 30% of the canal goes untouched of all those contents in the canal. So that's why irrigation plays such an important role. For us, the needles we use, side vented needles, and then we actually know the tip diameter of those needles is a point, almost like a 0.3 or 30 file. So I'm going up to at least a 3004 for me, because I know that needle is going to length, and I'm actually measuring. Once I get my working length, I measure my needle, I'm bending it at that measurement, and I'm taking it to the same reference point. So I know that irrigation is going to length. So depending on the tooth, the canal, these larger canals, maybe you know that needle is going to go right away. Also, depending on the pre-op diagnosis, is it a retreatment? But I think now with these NiTi files, and the differences in taper, the trend is going a little more conservative than it used to be in the past. Even from when I started training as a dentist, we were using 06 tapers, where now 04, and because irrigation methods have evolved with irrigation activation, there's different types, negative pressure irrigation, all these things, that because the irrigation is going up, our preparation sizes, it seems to be, are going down. So there's not a magic number, but all those things kind of combined. For me, it's 25, 30, but it's really, to me, all about getting that irrigation to length.
Okay, nice. John Cross, are you there?
Mm-hmm. Oh.
Yes, I am.
Yeah, please ask you have 2 questions on there. Please go ahead.
Yes, so you touched a bit on crowning, endodontically treated teeth. So I wanted to know, what is the major determinant of whether you need to crown a tooth? Is it because of the loss of dentin that goes with endo treatment, or is it because of devitalization? Because these, depending on what is the major determinant, that could tell you if you need to crown an endo-treated tooth that has been minimally prepared. That means it has lost little dentin or not. So what's the major determinant? The
major reasons, yeah. So there have been studies, because we get that, I get that question a lot, especially with, does endo treatment weaken the tooth, all those things. So there was a study that has shown that prepping a tooth for even like an MOD restoration, a filling, is removing more of the strength than it does for an access for a root canal. So major reasonings, I think posterior teeth that have lost like MOD previous restorations, things, it just is increasing risk of fracturing, saying if the tooth had an MOD, DO, all those things, we do the access, you're filling it with just leaving it in the composites. There's just been a lot of literature that's shown that long-term, these teeth aren't, the prognosis is not as good. And a lot of that's just due to fracture, and then reinfection is what we see. We kind of all know that composites themselves over time can leak. So if we're just relying on that as to seal in the coronal portion of our root canal, because I see that a lot where the teeth have not been restored with crowns for posterior teeth. And over time, we get some leakage and the tooth is getting reinfected. So I think posterior teeth as opposed to anterior teeth, there's kind of more reasons to crown, where an anterior tooth, you said, we're keeping those accesses very small. It's not an occluding surface. Those we're not necessarily recommending. But it depends on the tooth. And I think it just depends on the diagnosis too, and the previous restorations, things like that.
Okay. I mean, that's a full-blown webinar right there, and
Right there.
restoration of endotreated teeth.
Yeah, Dr. Uvoh, you can answer that.
Yes, we are going to come back to deal with that, but that's a very good question. I do have a Robel from Ethiopia. What is your question, Robel?
Sorry, I still have a question.
Well, hold on. Just hold on 1 minute. Let me get to Robel from Ethiopia.
Okay, sure.
Yes, hello. Can you hear me?
Yes, we can.
My question is basically on non-rotary filing system with the step-up technique, to be specific. Maybe I wanted to know more on how to identify the initial apical file, master apical filing, and how it goes hand in hand with the gutta percha that we use, whether it's plasticized or thermoplasticized or chemoplasticized or etc. And also, again, more on taper. Do we keep the same taper? For example, you said 30.04, that 04 part for our incremental use of filing number as well, like for 25, for 15 after we go to 20 and then 25 and then 30 and then etc. Do we use the same taper, or we do increase the taper as we file up? Thank you.
Yeah. Okay. So I can kind of squeeze in a couple questions. I'll try to see just the one you just asked. So I maintain the taper. I know some of it too, I think, is depending on the system you buy. You don't, if the principle is to get the irrigation to length, you don't necessarily need to change tapers. If you can accomplish that with the 04, like I strictly stay with the 04 taper my entire sequence. And I also get gutta percha that is an 04 taper. So you can, for me, it just makes it easier that if there's changes, I can quickly do these changes. I have my K files at 02, but once I get into the rotaries, I take everything up to 3004. I'm getting my gutta percha that is also a 3004, seeding that to length, but also checking that tug back. If something happened in the preparation, or if it was a retreatment, it's been over prepared, I just like the standard ones because I know I can clip off like a millimeter of my gutta percha cone and kind of mathematically determine, oh, this is where I'm at in diameter. And it kind of jumps between, do I need to go up? Let's say I'm at a 3004. Do I jump to a 3504 versus clipping it? There's just, it just to me is a lot easier. And it's my personality that I like knowing the math. That's why I stick with the standard taper. With the variable taper file systems though, they make matching gutta percha. So you can still use standard gutta percha if you want, and you're just going off that tug back. But if you're going to buy a certain file system that's variable, a lot of them will provide, at least that I've seen, a matching gutta percha cone to that master file. So there's no same where you're almost just, oh, I ended in this, now I'll fill with this. Not to say you can't change it, but your other question, I think, was regarding, what was it with the hand filing?
Yeah, on the step-up technique specifically, on identifying the initial apical file and the master apical file, and how it goes hand in hand with the gutta percha that we use finally, because here in Ethiopia, usually the gutta percha is not as well tapered as the filing that we use. So there is a bit of complications as we use accessory gutta perchas as well to accommodate the space.
So yeah, just the tricks to get it to cut out that extra work. What gutta percha do you usually have available, or you just feel like it's not within the same like they're not manufactured the same?
Yeah, basically they're not manufactured the same. Also, the taper is, as we file up using the step-up technique, obviously the coronal portion goes more wider, and that's how the gutta percha should fit in, starting from the whole length. So basically in Ethiopia, yes, there is the gutta percha that we use in the master apical file, but it's only seated apically and it does not extend coronally. It does not get bigger coronally. Hence, we use accessory gutta perchas.
So one recommendation that I
go
run into, one suggestion, because I have that a lot with anterior teeth, where very big canals. So if you could have available a known like 04 taper set of gutta percha and an 06, one way of knowing that the 06 is going to length, we call it without that false tug back, is you could try, say you end whatever file you end in a 3004, but it's a very wide canal. You could still try your gutta percha cone in, that's a 3004, that smaller taper, as long as that seats to length, like you have good tug back, you're comfortable with the seating, and you know you have all this extra space because the taper is big, then you could jump to the 06 taper, like you said, get a bigger taper, the 3006, and knowing that that apex is still maintaining that 30, but you're kind of filling in that space coronally that you may have had, as opposed to placing all those lateral canals. But I'm still doing almost like a warm lateral similar version, where even if I'm doing the 04, the main thing is maintaining that apical seal, depending on what obturation technique you use. But I'll do that where I'll know if I'm at a 3004, I'm still using the 30, but I'll may fill with the 06 taper. That is definitely okay.
Okay. All right. I know we're running out of time here. I'm just going to see if you can combine the answers to, there's a second question by John Cross. Are you good with time? Are you okay? You have another appointment?
Yeah, I'm good.
Okay. It says it's something about if you are not able to get rid of the prions during sterilization, does it mean that automatically we now have to do single use?
No, so my understanding, even because I didn't know that the reason they come, so whatever they use, they are pre-sterilizing them. They are sterilizing them a certain way to get rid of them, where our autoclaves do not. That's why they come pre-sterilized.
Okay. And somebody, Arnold was asking again about the mathematical, the concept of tapering. That was a little bit confusing. I don't know. Are you able to go over that just one more time?
Definitely. I agree. For me, I didn't think I really picked it up when I was in school until I did my training. So what it is, and they always use, if you look it up online, this D, it's basically, again, with, let's say, a 3004 file. Let me see. I even brought a 3004 means that the tip diameter is 0.30 of a millimeter. So very, very, very tiny, right at that tip. So we know that the tip diameter is 0.3, and as we go up, let me just see. I don't know if this will work where I can show you. Let me see. Can you read this or no? It's backwards.
Yes, it's good.
Oh, it's okay. Okay. So this is just really quick, and I've explained this several times. So let's say let's say I finish with a file that's a 3004, the 30 being the tip size, that 0.3 millimeters, the 04 is the taper. So every millimeter that I go up on the file, you can see, because it's this tapering shape, the file is getting bigger. But how much bigger is it? So 1 millimeter is just the 0.3 plus 0.04. So at this point of the file, it's 0.34. I go up a millimeter, I add 0.04, it's 0.38. I think it really made sense to me when I saw it on a K file. Like I said, that number 10 K file, where it's a much smaller taper, a 0.02, a 2 taper. So a 10, and most people don't talk about the tapering on the K files, but what I do is, let's say I have a very calcified canal. I feel comfortable. I'll actually clip the end off of some of either an 8 or 10 file because I just want that cutting edge to be a little bit sharper. So maybe we have 0.10 here. So if you understand the taper of the K files, it's a little easier because you can see it as well. So let's say I'm working with that purple number 10 K file. That tip diameter is 0.1, very, very, very tiny. Or let's say the end of it broke. The end just got bent and I don't want to use it necessarily. What I'll do is sometimes clip off just the end of it, 1 little millimeter. And then based on this standard taper, that end tip is now 0.12, like a 12, almost like a 12 file. So let's say I had an 8, I started with a number 8 file. Same, the taper is always 0.02 for these K files. If I were to clip a millimeter off a number 8 file, the very tip of it, it would now be equivalent to a number 10 file. So if you kind of can picture it in that sense, these same principles apply to the rotary files, but maybe you're not able to cut them. So it's more so just understanding the diameters of them as you go up the file, because that's what we're saying with determining the right gutta percha cone. You kind of want to know, and it really plays in if you're instrumented maybe past the apex, where that stop's going to be and kind of how wide it is on that file. If that makes, I don't want to get, some of it, it's easier if you kind of see it in person. For me, I kind of, and once you kind of understand it, that principle to at least the hand files, you apply similar to the rotary files.
Okay. All right. Thank you so much. I know this is an interesting discussion, and it can actually go on and on.
Oh yeah.
Thank you so much. This has really helped. I'm sure we're going to go back and watch these videos and just. You gave a very, 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 very lucid information. We're going to go back there and look at those slides. You listed the points. So, I think it's something to go back to. So I'm going to put it up on YouTube later today. And if you have questions, you can put it on the YouTube channel. Just ask the question there. I'm going to see how to drag Dr. Steffens down there sometime to answer your questions. There will be a lot of questions. Thank you so much, guys, for joining from Nigeria. I see all there's so many professors in the dental school who are on here today. So I believe that as this information goes forth, they're going to be teaching their students and their residents, and also practicing dentists from around different parts of Africa on here today. Thank you so much, guys. And we're done for today. I know that if we leave it open, and there'll be more questions. But go to I put it the YouTube channel. I need you to subscribe, so when I put it on there, you'll be aware of when it's posted, so you can watch it and ask your questions. Thank you, Rebecca. This has been invaluable resource to us. I mean, you don't know what you have done today. You have helped so many doctors around Africa to understand just the basics of Rotary Endodontics. Thank you so much.
Of course. Thank you, Dr. Uvoh, for having me.
Okay, then. You take care.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator